Hello everyone, this is my presentation on prescription drugs for endometriosis. My name is Valerie. So what is endometriosis? It is a condition in which cells similar to the lining of the uterus or the endometrium grow outside the uterus. Endometriosis often involves the pelvic tissue and can envelop the ovaries and the fallopian tubes. It can affect nearby organs, including but not limited to the bowel and the bladder. An average diagnosis takes about 10 years. Endometriosis can only be diagnosed by a surgery called laparoscopic surgery. This is where they'll make a small incision in your abdomen so they can insert a tiny tube with a camera. There are 4 stages of endometriosis identified by the location, amount, depth, and size of the endometrium tissue. The picture provided has more information, so if you would like to pause while I continue, you are more than welcome to. The first prescription drug I will be going over is opioid. I decided to do 3 common types since endometriosis varies and there are different approaches. I've broken it down between 3. The first is Tylenol 3, the second hydrocodone, and the third oxycodone. I also have added what it is, the strength, and the types of brands. Tylenol 3, also known as a codeine, is the weakest of the 3. It is often used for mild to moderate pain because the body has to convert it into morphine in your liver before it can work. The next is hydrocodone. A popular brand is Vicodin. It is significantly stronger than Tylenol 3, roughly 6 times stronger than the codeine. Usage, it is usually reserved for moderate to severe pain. The last one is oxycodone. It is generally considered the strongest of these 3. It is more potent, meaning a smaller dosage of oxycodone produces a strong effect than the same dose of hydrocodone. On this slide, I've provided another breakdown, but this time by generic name, drug classification, manufacturers, and dosage. As for the potency note for Tylenol 3, this is used for more mild to moderate endometriosis pain. Again, it is the weakest of the 3. It is often the step-down medication used when a patient is ready to stop stronger opioids, but still needs more than just over-the-counter pain meds. The second is hydrocodone, also known as Vicodin. Hydrocodone is used for more moderate to severe pain. It is roughly 6 times stronger than the codeine. It is very common for the post-surgical endometriosis pain. As for the last one is oxycodone, also known as Percocet. It is used for more severe pain. It is the strongest of the 3. It is typically reserved for the first 24 to 72 hours after a major excision surgery for endometriosis. Excision surgery is where they will go within your abdomen and they will remove endometrium tissue where it should not belong. So endometriosis tissue should be within the uterus, but it can grow outside, so they will either burn it off or carve it out. It is a very painful surgery. And they will most likely have to do it more than once. And so that's what the excision surgery for endometriosis is I'm talking about. So how does opioids work against endometriosis? Well, talking about Percocet, it acts as a high-potency mu opioid receptor agonist. It binds the receptors in the brain and spinal cord to close the gate on ascending pain signals. How it works, it changes the effective response to pain, meaning it alters how the brain feels about pain, making intense trauma feel distant and tolerable. So why is it prescribed? Specifically for acute high-intensive pain immediately following surgical excision of endometriosis lesions. The symptom targeted are sharp stabbing surgical pain and deep tissue trauma that over-the-counter medication cannot reach. Moving on to Vicodin, it works by using a dual mechanism approach. The hydrocodone numbs the nerves, while the antihistamine reduces the chemical volume of the pain in the pelvic cavity. Why is it prescribed? It's prescribed for moderate to severe flares or the mild stage of post-operative healing. So symptoms targeted are heavy gnawing pelvic aches and inflammatory endobelly pain. Pain is a huge thing when it comes with endometriosis. It is top 20 most painful conditions. Moving on to Tylenol 3 and how it works against endometriosis, it provides a milder, slower acting suppression of the central nervous system compared to oxycodone and hydrocodone. So why is it prescribed? It's used as a step-down therapy to help patients transition from heavy narcotics back to normal life. The symptoms targeted are dull, throbbing cramps and lingering post-surgical soreness as the nerves begin to settle. So why are opioids prescribed? Well, they all treat the feelings of pain, but they do not stop the endometriosis from growing. They don't stop the bleeding, but they do stop your brain from panicking when it receives a pain message from your pelvic area. So doctors prescribe these because endometriosis pain can be so loud that it causes your whole body to tense up, which actually makes the pain worse. By silencing the alarm, these drugs allow your muscles to relax and allow your body to rest so it can heal. Moving on to the risk and how they are administered, some of the common side effects for opioids are nausea, vomiting, and opioid-induced constipation, drowsiness, brain fog, dizziness, and impaired physical coordination. It can cause itching, especially common with codeine, which is the Tylenol 3, due to a histamine release. As for more clinical risks, slowed or shallow breathing can occur. This is the most serious risk, especially if the dose is too high or mixed with alcohol or sedatives. Another potential risk is liver damage. This can happen if it is combined with other Tylenol products. Also, the body can develop a tolerance, which can cause the person to get higher dosages. How is it administered? It's usually taken every 4 to 6 hours for the first 2 days to stay ahead of the pain, rather than waiting for the pain itself or waiting for it to hurt. Also, take each pill with food and a full glass of water to prevent nausea, and start a stool softener immediately to avoid constipation. As you feel better, gradually space your doses further apart and transition to over-the-counter medication like plain Tylenol or Advil to do a step down safely. The second prescription drug I decided to talk about was hormonal birth control or hormonal therapy. The first is Orilissa. It is a high potency pill specifically for endometriosis rather than general birth control, meaning it quickly lowers your estrogen levels to put the body in a temporary reversible menopause-like state. I've actually taken Orilissa, and when it talks about menopausal-like state, it talks about hot flashes, night sweats, everything you can think of when it comes to menopause. The second is progesterone-only pills. These are often the first choice because they don't contain estrogen, which can sometimes aggravate endometriosis symptoms. The third is combined oral contraceptives. These contain both estrogen and progesterone. They are common but often less effective for severe endometriosis than the options above. On this slide, I've broken down the 3 hormonal therapies upon classification and manufacturer. I've chosen the 4 common hormonal treatments for managing endometriosis. The first is Orilissa. This is a specialized hormonal blocker that directly targets the receptors responsible for estrogen production to help reduce pain. Next, we have 2 types of oral contraceptive. SLID is a progesterone-only pill, which is often a great option for patients who can't take estrogen. Then there is Yaz, which is a combined pill, meaning it uses both progesterone and estrogen to help stabilize the cycle and manage symptoms. Finally, there's Lupin. This is an injectable medication known as a GnRH agonist. It is a stronger treatment designed to temporarily suppress the hormones that cause endometriosis to flare up. So how does hormonal treatment or birth control work against endometriosis? Well, all of these medications share one primary object: estrogen suppression. Endometriosis is estrogen dependent, meaning the lesions can grow and bleed in response to your natural hormones. All these drugs work to lower estrogen or block its effect to starve the endometriosis tissue. Here are the risks in administration of the most common hormonal treatments for endometriosis. First is Orilissa. Some of the risks are bone density loss, hot flashes, night sweats, and mood changes, depression. The second is Igestine. The risks are weight gain, fluid retention, breast tenderness, and breakthrough spotting. The third is Slide. The risks are irregular bleeding, potassium changes, and headaches. The fourth is Luprin. with the risks of significant bone loss, intense hot flashes, and flare of symptoms in week 1. And the last is yes, the risks of blood clots, nausea, and mood swings. So it is vital to understand how these treatments impact the body's ability to move and recover. We can break this down into 3 main categories: opioid impact, hormonal impact, and the impact of endometriosis itself. First, opioids can cause impaired coordination, like dizziness or drowsiness, which can increase the risk of falls. They also suppress vitals, meaning our heart rate and breathing can slow down, making you feel fatigued faster. A very common side effect is also pelvic discomfort caused by constipation, which can make core exercises particularly uncomfortable. Next, our hormonal treatments like Orlissa or Luprin can lead to thinner bone density. To combat this, we highly recommend light weight-bearing exercises like walking. These medications also block estrogens, which can cause hot flashes or overheating during cardio, and may even slightly slow down how fast your muscles repair themselves after a workout. So it is not recommended to do running, more of like walking, slow exercises when on those medications. Finally, the disease itself causes what we call pelvic guarding. This is when the abdomen muscles stay tight to protect the painful area, leading to hip stiffness and poor posture. Patients may also find that high impact movements like running can trigger sharp pelvic shocks, or as I like to call it, lightning crotch, and the general inflammation of the disease can often require longer recovery times between sessions. To wrap this up, it's important to remember that effective endometriosis care isn't just about one pill or one surgery, it's about the balance. We want to use hormonal suppressions to stop the disease from progressing, but we also need a multidisciplinary team to treat the whole patient. This team usually includes physical therapies, therapist, mental health support, and diet, nutrition. For example, by integrating low impact exercise and physical therapy, patients gain non-drug tools that help manage pain and, importantly, protect bone health, which can sometimes be affected by hormonal treatments. This holistic approach is our best strategy for reducing the daily burden on opioids. We can have a strong support system in place. We can ensure that stronger pain meds remain a strictly short-term tool for emergencies, which directly prevents the risk of long-term prescription misuse. So the key takeaways today are: first, treat the root. Use hormonal therapies to address the underlying disease. Second, build a safety net. Use physical therapy and mental health support so you aren't carrying the burden alone. Third, exercise as prevention. Keep the body moving to release natural endorphins. And the last one, control the risk. Keep opioids in their proper place and use as a limited short-term option for acute recovery only. Thank you so much for your time. I hope you enjoyed. And here are my references. So if you would like to do further research upon yourself, if you want to do a deep dive on endometriosis and opioids. Thank you so much.